the management of aortic dissection. Welcome to our podcast, where today we are delving into the critical topic of managing aortic dissection. We will guide you through every phase, from the initial suspicion all the way to long-term follow-up, ensuring you understand the nuances of effective care at each stage. Introduction to aortic dissection. An aortic dissection represents a life-threatening emergency. It occurs when a tear develops in the inner layer of the aorta, allowing blood to surge between the layers of the vessel wall. This creates a false passage and can lead to serious complications, including blockage of arteries that supply vital organs, resulting in conditions such as stroke, heart attack, kidney failure, or limb ischemia. If the entire wall tears, catastrophic bleeding and rapid death can ensue. To guide management decisions, we use the Stanford classification system. In this system, Type A dissections involve the ascending aorta, and demand immediate surgical intervention. Type B dissections are limited to the descending aorta and are often managed medically, unless complications arise. Phase 1. Pre-hospital and emergency department management. Initial care focuses on rapid stabilization and confirmation of diagnosis. Aortic dissection should be suspected in individuals presenting with a sudden, severe, tearing or ripping chest pain that radiates to the back, especially if there is a history of high blood pressure. Basic principles of airway, breathing, and circulation are paramount. If the patient is unconscious or struggling to breathe, securing the airway is essential. Establish intravenous access with 2 large lines to ensure rapid delivery of fluids and medications. The most important early intervention is controlling blood pressure and heart rate to prevent progression of the dissection. The goal is to maintain a systolic blood pressure between 100 and 120 millimeters of mercury, or as low as possible, while ensuring vital organ perfusion. The heart rate should remain below 60 beats per minute. Beta blockers, such as esmolol, labetalol, or metoprolol, are the preferred medications since they decrease both heart rate and the strength of heart contractions, thereby reducing stress on the aorta. If beta blockers cannot be used, calcium channel blockers like diltiazem or verapamil are alternatives. Vasodilators, such as sodium nitroprusside, may be added, but only after beta blockade is achieved to avoid reflex increases in heart rate that could worsen the dissection. Phase 2. Definitive management based on dissection type. After diagnosis is confirmed, typically with computed tomography angiography, treatment strategies diverge depending on the type of dissection. Treatment of type A aortic dissection. Immediate open surgery is required for type A dissections. These cases are particularly dangerous due to their proximity to the heart, posing risks such as rupture into the sac surrounding the heart, which can cause cardiac tamponade, acute valve failure, blockage of heart arteries, and extension into the brain's blood vessels. Surgical intervention involves removing the damaged section of the ascending aorta and replacing it with a synthetic graft. The aortic valve may also need repair or replacement, and in some instances, a composite graft that includes both the valve and the root of the aorta is used. Despite advances in surgical techniques, these procedures carry a significant risk of death, even in experienced medical centers. Management of type B aortic dissection. For type B dissections, intensive medical therapy is the first line of treatment. Patients are admitted to the intensive care unit and receive intravenous blood pressure medications, primarily beta blockers and vasodilators, to ensure tight control of blood pressure and heart rate. Careful monitoring is essential to detect any signs of complications. Intervention becomes necessary if complications arise, such as persistent pain or high blood pressure, evidence of organ or limb ischemia, rapid expansion of the aorta, or impending rupture. In these cases, the preferred procedure is thoracic endovascular aortic repair, a minimally invasive technique where a stent graft is introduced through the femoral artery and deployed in the descending aorta. This covers the primary tear, redirects blood flow to the true passage, and encourages closure of the false passage. Thoracic endovascular aortic repair has largely replaced open surgery for complicated type B dissections due to its lower risk profile. Phase 3. Long-term management and follow-up. Survivors of aortic dissection require lifelong care. Medical therapy focuses on strict control of blood pressure, with a target systolic pressure below 130 millimeters of mercury. Beta blockers remain central to therapy, supplemented by medications such as angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, or calcium channel blockers. Lifestyle modifications are essential. Patients should avoid heavy lifting and exercises that dramatically increase blood pressure. such as those involving the Valsalva maneuver. Smoking cessation and cardiac rehabilitation are strongly encouraged. Regular imaging, using computed tomography, angiography, or magnetic resonance imaging, is critical to detect late complications, such as aneurysm formation or progression of the dissection. Imaging is typically performed at 1, 3, 6, and 12 months after hospital discharge, and then annually if the patient's condition remains stable. Genetic screening should be considered for underlying connective tissue disorders like Marfan syndrome, Loeys-Dietz syndrome, or Ehlers-Danlos syndrome, as these findings can influence both management and recommendations for family members. Summary and key takeaways: the management of aortic dissection is a complex, time-sensitive process. Success depends on rapid diagnosis, aggressive medical therapy to reduce stress on the aortic wall, and timely intervention tailored to the specific type of dissection. Surgery is mandatory for type A dissections, while thoracic endovascular repair is the preferred approach for complicated type B dissections. Lifelong surveillance and strict medical therapy are essential for long-term survival and quality of life. Thank you for joining us today. If you found this discussion helpful, please like, share, and subscribe to our channel. This is the Everything Surgery Podcast, where we dissect the extraordinary.